Next, I call upon Dr. Kumar for his presentation on intractable post-ocular blunt trauma, related hypotony managed with an encircling 240 band.
Good afternoon, everybody. I have no financial disclosures to make. The aim of the presentation is to report 6 patients who had intractable post-ocular blunt trauma-related ocular hypotony, and we managed these patients successfully with an encircling band, which is a well-described procedure for such patients. Is just to report our experiences after conservative attempts at treating this hypotony had failed. So we had 6 patients, out of which 5 were men and 1 was a lady, and with age ranges between 8 to 54 years. And the method of injury, the way in which the injury was sustained was with a tennis ball while playing cricket in 3 young patients, fist injury in domestic trauma in 2 patients, and accidental fall of an object from a height in 1 patient. The pre-treatment intraocular pressures varied between 6 to 9 millimeters mercury. No cyclodialysis clefts could be seen or an occult rupture seen in these patients. We did attempt to do gonioscopy even after filling up the anterior chamber with visco and putting in pilocarpine drops, but no cyclodialysis clefts were seen. 4 of them were subjected to anterior segment UBM as well, but we couldn't identify a cyclodialysis cleft in any of these patients. All 6 patients had hypotonic maculopathy, and serous choroidals with choroidal and retinal folds were seen in 2 patients. These are some of the pre-treatment UBM pictures in these patients. So we did try a 6 weeks course of topical Predfort eye drops along with cycloplegics in these patients, and an anterior subtenon stricot also was tried in 2 patients, and 1 patient had a transconjunctival cryotherapy for an infranasal dialysis without detachment. Finding that there was no response to any of these, we decided to, as a last throw of the dice, or rather a penultimate step before the last throw of the dice, which is usually a vitrectomy and allied procedures, we decided to do encircling band with a 240 band. This is more of a blanket treatment which would, by physical apposition of the cyclodialysis cleft to the overlying sclera, close the cyclodialysis cleft. Mattress sutures was placed in all patients. Because of the hypotony, we thought it would be better to use sutures rather than try to create a scleral tunnel in these patients. We needed the use of intravitreal layer in 4 patients to firm up the globe during the encerclage itself. Sorry, I don't have a video because we didn't really record these. Basically, it was placed just behind the insertions of the rectus muscles. And the way it works is thought to be due to apposition of the sclera to the ciliary body and helps close an undetected cleft that could be causing the persistent hypotony. So coming to the results, the intraocular pressure rose to 16 to 17 millimeters by the 4th post-op day in all patients. 2 patients unfortunately developed secondary raise of intraocular pressure to the 30s, but those were successfully managed medically. We had a young boy whose cataract progressed and he needed phacoemulsification cataract surgery later, about a year later. No long-term complications of this procedure have been seen in any of these patients except for a mild increase in the myopia of these patients, the axial length and consequent myopia in these patients. So these are some of the pictures. This is 1 patient who was pseudophakic and had hypotonic maculopathy with serous choroidal and retinal folds, detachment, and pre and post-treatment pictures. This is the patient, this is the picture of the young boy who had a tennis ball injury, persistent hypotonic maculopathy with disc edema, and the progressive sequential improvement in the disc pictures with time. And subsequently, this patient underwent cataract surgery as well. So post-traumatic hypotony could be due to a cyclodialysis cleft or a ciliochoroidal detachment or a persistent uveitis. Various methods of treatment are enunciated in the literature. Vitrectomy and gas is really the last throw of the dice before we do any intraocular procedure, particularly considering that many of these patients are young. Scleral buckle, encircling buckle offers us a safe and elegant technique with minimal risks and is extraocular and can be attempted prior to intraocular procedures. Thank you very much.
Have you documented the myopia which came in? Do you have a record of the amount of myopia and change in?
Yeah, about 1.5 to 2 diopters on an average.
more of cylindrical or?
They did have a small element of cylindrical also, but we didn't tighten the band too much because we didn't want to. The idea was to just oppose, because then if we tighten too much, there might be a kind of a fish mouthing of the cyclodialysis cleft as well.
How do you titrate the tightening on table?
On table, it is
Purely digitally.
digital pressure is digitally on the globe. Obviously, the other way is to just lift up with a muzzle hook and then it should just flap back onto the sclera.
I have one question. You said there was no cyclodialysis on UBM.
Right.
The cleft could not be seen on a.
We did UBM in 4, but we did gonioscopy in all patients.
No, was there a cleft seen on UBM? Or
No, in none of the patients was a.
So it was a presumptive diagnosis.
Presumptive diagnosis of
cyclodialysis.
Yeah, but there was no evidence of a ciliocoroidal detachment on the UBM
Okay.
either.
So the encircling band has worked in all your patients.
Yes.
That itself is probably proof that it was a cyclodialysis.
Right.
Because the mechanism that you explained was that it will cause an indentation and approximation.
Correct.
Of the
Apposition of the.
apposition.
Right.
So probably it was a cyclodialysis.
And
In fact,
yeah,
it's not picked up.
in
on-
more than 70% of the patients, the literature, the incidence of detecting the cyclodialysis cleft or visualizing the cyclodialysis cleft varies anywhere between 30 to 70%. So quite a large number of them, it may not be seen because the globe is hypotenuse and
On gonioscopy, could you guess where the cyclodialysis was?
not really, because we couldn't really suspect the cyclodialysis cleft in any of these patients at all.
Could there be a secondary effect of reduction of the venous outflow because of the band leading to a rise in IOP?
But that would have produced other symptoms in the anterior segment, such as flare, Descemet's membrane folds, something like the anterior segment ischemia-like manifestation. None of these patients had any signs of anterior segment flare
Minimal
cells.
effect without.
Yeah.
So that would add on to your increase in IOP.
Possible. Possible. That could be another mechanism operating.
There are many more questions, but we will move on because we have many
Thank
more
you.
papers
Thank
to be
you.
presented. Thank you.